EUS-guided gallbladder drainage. This is a topic that's really dear to me because I lost a patient where I had attempted EUS-guided drainage of the gallbladder. At that time, this is over a decade ago, using the Seldinger technique and placing a SEMS. This patient developed a leak, a bile leak, and peritonitis, and subsequently sepsis, and died. And so that inspired me to start giving some thought about how we can make EUS-guided drainage safer. My objectives are, first, let's define the current standard of care for the management of acute cholecystitis. When I outline the rationale for EUS-guided gallbladder drainage, review the existing evidence supportive of EUS-guided gallbladder drainage, and finally, let's list the current indications for EUS-guided gallbladder drainage and possible areas where EUS-guided drainage will replace lap chole. All right, so the current standard of care, and this is very nicely summarized by the Tokyo guidelines this year, and basically they state that laparoscopic cholecystectomy in a patient presenting with acute cholecystitis should be performed within 7 days of admission. And they divide 3 grades. So if it's grade 3, then that is to say with organ or system dysfunction, that cholecystectomy should occur within 24 hours. If it's grade 2, an elevated white count greater than 18,000 with marked local inflammation on imaging studies, that should occur within 2 days, 48 hours. And finally, if it's grade 1, that's mild local inflammation, then that should occur within 3 days, although they do allow up to 7 days for the cholecystectomy. So what are the reasons for delaying an emergency surgery in a patient arriving with acute cholecystitis? Well, that patient may be acutely ill, just too sick to undergo surgery, may have acute pancreatitis, may be high surgical risk with significant comorbidities, or there may simply be practical issues like staffing shortage or OR access. And therefore, we have this concept of the bridge to surgery, and this has been provided by percutaneous drainage. Percutaneous drainage, it's been around a long time, first described in 1980. It is well standardized, it is widely available around the world. It is a bedside procedure. It can be performed under ultrasound guidance. It doesn't require fluoroscopy. It can be done just with a local anesthetic or with just very minimal sedation. It has a near 100% success rate, and it has been shown in many studies to have negligible impact on lap chole. So actually, a very, very nice procedure that has been validated over and over, but it still has limitations and drawbacks. There are contraindications to percutaneous drainage, ascites, coagulopathy, if there's intervening bowel. For the patient, it causes discomfort on the skin, and of course it's unsightly. It requires daily tube maintenance, and there are problems that can occur, like leak and infection and blockage of the tube. It can result in a non-healing fistula after the tube is removed. And in those patients who have the tube removed, these patients will very frequently develop recurrent cholecystitis, 41% in one study. This study, for example, published last year, looked at the fate of the cholecystostomy tube following percutaneous cholecystostomy, 244 patients. So what they found was 3.7% of the patients actually had to be readmitted within 30 days of their tube placement. 19%, so a fifth of the patients, had tube issues, leakage, dislodgement, occlusion, even bleeding that had to be treated in a hospital setting. So what is then the rationale for EUS-guided gallbladder drainage? Well, firstly, as all of us who do EUS know, the gallbladder is easily visualized, typically from the bulb, best from the bulb, but can also be visualized from the antrum, and it's very easy to access. In fact, those of us who do pseudocyst drainage can very easily mistake the gallbladder for a pseudocyst, and I've done it. It's an internal drainage, so there's no maintenance required. And it provides the opportunity, should we be able to create a port to enter into the gallbladder from the bowel for direct gallbladder intervention. But most importantly, and this is for me very critical, it preserves gallbladder physiology. We're not draining the bile that is so critical for our digestive system. We're not draining it out, it's being recycled into our bowel where it belongs. Now, what are the limitations and drawbacks of EUS-guided gallbladder drainage? Well, we all know these patients need deep anesthesia for these complex EUS interventions. The gallbladder is a non-adherent organ. So it's only in those patients that have chronic cholecystitis where you may have some adherence. Usually it's not adherence, it's freely mobile structure. So we can get leakage of bowel contents and gas and bile and subsequent infection. If we place a stent, it doesn't matter what stent we place, we're going to get fusion between the gallbladder and the bowel wall, and this may complicate later cholecystectomy. And then, of course, there's the cost issue relative to percutaneous drainage. This is clearly more expensive. So we started off with plastic stents, and you can see here 3 case series, and these were all patients with acute cholecystitis, high risk, unresponsive to antibiotics. Great technical and clinical success, so we can clearly do this, but there was a 25% complication rate with bile leak in 2 patients, gas leak in 2 patients, and migration in 1. And so we've transitioned, we've moved on to using expandable metal stents, fully covered, of course, with the rationale that this is going to seal off the tract. It's also going to provide a larger opening for drainage. So we've used covered biliary SEMs, but of course these don't have any flanges for anchorage. So these SEMs have been modified to become biflange SEMs. And then more recently then the lumen opposing metal stent, which is not really a biflange stent. This is truly lumen opposing. It's holding 2 lumens in apposition. Now that's only one part of the equation though, the stent. The delivery of the stent is also an important part of this equation that can lead to leak and infection. The Cellular technique is a multiple step, multiple risk technique. So you can see all these different steps that we take, exchanging tools over a guide wire, and with each of these steps we risk leak, displacement of our target organ, the gallbladder, from the bowel wall. It's going to start shrinking on us. It can move away from the bowel wall. When we dilate our tract up, that can result in frank perforation and leakage. When we remove our dilator, leaving that guide wire in place, there's a step off and there can be leakage. And then when we put our stent in, even that can push the gallbladder away and we'll get displacement of the gallbladder from the bowel wall. So that inspired me to think about a system, a delivery system that would allow us to insert this stent with just 1 single puncture, whereby our tool actually seals off the tract completely so that we can 100%, absolutely, eliminate the risk of leakage. We have to eliminate that risk to make this a safe procedure. So it has to be 1 step, it has to be with 1 device, and it has to be exchange-free, which means non-Seldinger. We access the target lumen with a stent-loaded catheter, and we immediately deploy stent. And here are some of the early drawings that I made over a decade ago as I tried to conceptualize how this might look. And so this is how now the procedure has evolved. This is the hot lambs demonstration of gallbladder drainage in a patient with septic cholecystitis who was not a surgical candidate, and these are the only patients that we should be doing this on now. You can see how we can easily puncture through with that hot puncture. We see the tip of the sheath in the gallbladder. It's abutting against the distal wall, so we have enough space to now deploy our distal flange. You saw the different steps yesterday. The black hub is retracted to position the distal flange snug up against the duodenal wall. Then the gray hub is fully retracted to deploy the proximal flange, and we deploy that inside of the working channel. So we stay under ultrasound guidance until the very end, where we push the proximal flange, deployed in the working channel, out into the lumen of the bowel, the bulb or the antrum. Next, we can then dilate the lumen of the lambs, And since this is the 10 millimeter lambs, we can dilate that to 10 millimeters. And if you have a pediatric gastroscope available, you can pass through the lambs into the gallbladder and inspect. And now you can see how we've really extended our reach of endoscopy to an organ that previously was completely hidden to us. So now this has become part of our territory. And you can see the stones in there, and you can remove these stones. You can even do direct lithotripsy under endoscopic guidance. There are a couple stones coming out. So what we have to date are really just case series. And I've just summarized here the case series that report more than 5 patients. I mean, unfortunately, we have many series with just 1 or 2 patients. But if we look just at those with more than 5 patients, we're talking about only 229 patients. Lambs were used in 5 of 8 of these series. And our technical and clinical success rates were great, but we still have a complication rate of 8%. Now, there's only one study among these 8 where they exclusively used the hot lambs, and that's in the last study that was published by Dolhoff. That was using the hot lambs. So what is the evidence supportive of EUS-guided gallbladder drainage? The status as of this month. I would say we have numerous case series, but these are all small and retrospective. We cannot call this data. This is not evidence-based medicine. We have 3 retrospective comparative studies comparing EUS with percutaneous, 2 studies, and EUS with transpapillary, that's 1 study. We have only 1 randomized study that compares EUS-guided gallbladder drainage with percutaneous drainage, and that study is comparing nasocystic catheter drainage with percutaneous, not stent drainage. And probably not a lot of us do nasocystic catheter drainage. So here's a summary of these comparative studies. You can see the first one, which was the randomized trial, EUS-guided gallbladder drainage versus percutaneous nasal cystic catheter drainage. EUS had a lower pain score. And as you look through these trials, you can see that in the comparison with percutaneous approaches, EUS resulted in lower pain scores, shorter hospital stay, fewer repeat interventions. The only downside was that the EUS-guided approach was costlier, but it really was offset by lesser interventions and shorter hospital stay. And then the one study that compared EUS-guided gallbladder drainage with transpapillary drainage, that showed that there was lower adverse events and lower cholecystitis and cholangitis rates. Now, I don't know about you guys, but it's been a while since the last time I placed a stent into the gallbladder transpapillary. So what are the current indications for EUS-guided gallbladder drainage? I would say it is an appropriate bridge to surgery for patients that are established poor candidates for percutaneous drainage. But you really have to restrict it to those patients that are poor candidates. In other words, really you have to have a radiologist say, yeah, I agree, I think this is a higher risk patient for percutaneous drainage. It's fair for drain internalization. That is to say, we're converting an external percutaneous drain to internal drainage, for example, for longer-term drainage, or when you have problems with that external drain from the maintenance issues, etc. And it certainly it could be an alternative to EUS-guided bile duct drainage. We heard about that earlier, but sometimes the gallbladder is simply easier to access for drainage than the bile duct. So you can just use the gallbladder, provided, of course, that it connects with the bile duct. So what about first-line treatment? When can we say that EUS-guided gallbladder drainage might be first-line treatment over percutaneous? Well, we need more studies, and these need to be randomized. We have to see that randomized trial of gallbladder EUS-guided versus percutaneous-guided as a bridge to surgery. In other words, we have to select those patients who have been identified as surgical candidates. They simply need that bridge. And we need to determine what the impact of EUS-guided gallbladder drainage is on the outcomes of lap chole. Should we be placing a SEMS or a LAMS? Should we use a Soldiger versus non-Soldiger stent delivery system? Should this be transantral or transbulbar? There are possible areas where EUS-guided gallbladder drainage will replace lap chole. Acalculous cholecystitis. These patients are usually very, very, very sick. Gallstone disease. I think if the gallbladder is otherwise healthy and we can establish that stone clearance long-term is durable. For patients with cystic duct obstruction, if the drainage is durable. And finally, and this I think is very exciting for the future because we're extending our reach to the gallbladder. If we have gallbladder polyps, large polyps, let's say greater than 1 centimeter, or early stage neoplasms. In other words, if we can establish an oncologic cure, then I think it's reasonable to extend our reach to the gallbladder. There are many open questions that need to be addressed. What are the risks and the impact of blockage from food impaction? There have been many questions about this, and should we therefore place it in the antrum, or should we, if we place it in the, in the duodenum, or if we place it in the antrum, should we place a stent, a double pigtail stent, through that lambs? And what would be the downsides of placing that pigtail stent through a lambs? If we have gallbladder stones, what's the optimal method and timing for stone clearance? And what kind of a follow-up should these patients receive? And for long-term drainage, should we remove the stent? And if so, when do we remove it? Are there risks of bleeding longer term, as we saw with the treatment of WAN? What is the durability of the drainage after the removal? Will the fistula stay open or will it close? This is a quote from a colleague, a very famous endoscopist, who said, "In the foreseeable future, after more data has been accrued and assessed, endoscopy may be included in the management scheme of cholecystitis." When do you think this quote derives from? 1994. This is Jerry Siegel. And at that time, he was commenting on the novel procedure of ERCP-guided or transpapillary gallbladder drainage. Dick Kozarek is the first one to describe this, and so he commented on this in this editorial. 1994, that means it's actually taken almost a quarter of a century to finally reach the point where I think endoscopic gallbladder drainage will become mainstream. Thank you.
Any questions?
Yes, Thomas.
I have a technical question. You wouldn't believe. Is there any experience if you put a lumps into the gallbladder and subsequent surgery? Is there a hole in the duodenum or what,
yes,
what happens?
There is actually. It's anecdotal. I did not go into it, but it's very interesting that actually it appears, number one, that it's very easy for the surgeon to remove the lambs and then just throw a stitch and close the hole. It's not like the entire gallbladder is now completely scarred in and the surgeon has to do a duodenectomy or duodenotomy or so. So it appears to be a fairly simple procedure for the surgeon. Now, a closure of the hole is necessary. Now, one question might be, though, could you remove the lambs, close it internally from inside, like an Ovesco type clip over the scope clamp, and then the surgeon subsequently does the cholecystectomy. So this is, I didn't go into this, of course, because all of this is very early and just anecdotal.
I think I agree with you, Ken, but we had directly the opposite experience. A patient was very, very sick in the ICU, and then we were told, well, she's not going to survive. We placed an aluminum-opposing metal stent, and then she got fantastic, got better, and then the surgeon did a 3-hour gallbladder surgery and converted a lap into an open, and he came red-faced outside, all upset that we placed a stent in this patient. So,
hence my caveats about needing more studies and more experience.
So, Ken, I wondered about your patient selection, which is really difficult, because when you say the patient is not fit for surgery, that means anesthesiology is kind of refusing to give patient deep sedation. Which category are we talking about?
I'm sorry, which what?
Which category of patients are we talking about? Isn't it a very small one if you only think at those that cannot undergo
it is, and that's why really you know, we have still a relatively small number of patients, because I'd like to think that our operators, our investigators, are truly adhering to a rigorous selection of patients for this procedure. So it should be for patients who are deemed to be poor candidates for percutaneous drainage, and at the same time are still able to undergo an interventional endoscopic procedure. However, it's really rare that a patient cannot undergo a interventional EUS procedure.
Thanks, Ken. Thanks a lot.